purpose of this presentation is to describe a newly discovered association between Ehlers-Danlos Syndrome and Chiari 1 malformation. The work is the collaborative effort, the joint effort of the Chiari Institute in New York and the NIH National Institute on Aging in Baltimore, Maryland. Our identification of a linkage between EDS and Chiari 1 malformation was greatly facilitated by the large and growing clinical database at the Chiari Institute. The surgical experience since 2002 is seen below, and more than half of the patients are referred for management of failed Chiari surgery. And so it was that our introduction to EDS came largely through the evaluation of patients with failed operations for Chiari 1 malformation. What we found was a small subset of patients who had no obvious surgical complications. Many of the patients that we routinely see have surgical complications. They have pseudomeningoceles, they have other problems. All these patients in the small subset had good anatomical decompressions. We see patients whose decompressions are too big or too small, but these were patients who had good anatomical results. The problem was that these patients were materially worse, in some cases, frankly, disabled by a good operation. So as we worked through initially with this group of patients, we were really working in the dark, and we didn't understand it ourselves. But gradually we found out that there was a recurring incidence of a problem that we have referred to as functional cranial settling or craniocervical instability, where the head positioned on the neck was not held together with the same strength and integrity that one would expect. And as it turned out, and we learned more about this, the vast majority of the patients with good decompressions who had evidence of craniocervical junction instability turned out to be patients with Ehlers-Danlos syndrome. Now, as a physician, I've heard about this condition and know a rudimentary amount about its clinical manifestations, but it was really quite foreign to us. This syndrome really comprises a group of connective tissue disorders. We say 13 here, but there may be more. And to some extent, they almost form a continuum of disorders which have in common certain features. They tend to show hyperelasticity and fragility of the skin. The joints tend to be hypermobile, and there is often a fragility of the cutaneous blood vessels and indeed even large arteries within the body. The fundamental problem in this disorder, known collectively as Ehlers-Danlos syndrome, but keep in mind that it has many different types of disorders, is a deficient quality or quantity of collagen, the tissue that holds us together in terms of ligaments and supporting structures, or a deficiency of collagen within the extracellular matrix that holds these elements together. The syndromes, and probably it's not a bad idea to put the S at the end of this connective tissue disorder, most of the forms tend to be passed as a dominant trait, an autosomal dominant trait. That's like brown eyes going through a family. It can be caused by the mutation of a number of known genes, and new genetic information is coming out as we speak. This is one of the very exciting parts of my life now for an old-timer, to be involved once again on something which is a cutting-edge and evolving specialty. But like syringomyelia, it's fairly rare. The incidence in the general population is given as 1 per 5,000 individuals. And it's been reclassified recently. Those of you who know about Ehlers-Danlos can remember an old classification scheme of EDS 1, 2, 3. It's now been revised a bit, although this classification itself has many failings. What we're hoping is that in time, the classification will be based and defined by the genetic defect. And to that extent, Dr. McDonnell is working on elements of this group of patients and disorders, and has as an ultimate objective to be able to reclassify this on a genetic molecular basis. These are the different types that we know. Classical type is a typical patient, has some hypermobility of the joints, but they tend to form atrophic scars. There's a history of poor wound healing. This is passed on as autosomal dominant, and the gene defects are noted here. I'm just going to touch on these because they will be now public domain, and people can look at more depth at these slides, and then I won't go into the details here. Pure joint hypermobility, pain, and the ability to spontaneously dislocate large joints is another common type. And the vascular type, in which there is fragility of the blood vessels, often with rupture of arteries, rupture of the uterus, history of bruising, small joint hypermobility forms the vascular type. 90% of the cases that come to clinical attention tend to be among these three types. And then there are other types too, and for those of you who want to view this later, it'll be on the slide. This is a demonstration of Ehlers-Danlos syndrome in a patient who has joint hypermobility. And you see the different manipulations, the hyperextension of the fingers, the opposition of the thumb to the wrist. This is a demonstration of some of the things that I know I can't do. Maybe I could do them when I was younger, but I certainly can't do them now. There's spontaneous dislocation of the shoulder joint. Here's spontaneous dislocation of the hip. There's patella dislocation. This is a otherwise normal functioning individual who has these extraordinary examples of joint hypermobility. She has Ehlers-Danlos of the hypermobile type. Now we actually, in making a diagnosis of Ehlers-Danlos, have to put this to some quantification. And so there is a score that we use, assigning points to these various tests that are done to quantitate the degree of hypermobility. This Baton score, like the classification of EDS, has limitations. It's not a perfect thing, but it's what we work with on a clinical basis. We describe hypermobility. We make that diagnosis if a patient is positive for 5 or more of the points here. Maximum score is 9. At this moment, the clinical diagnosis of EDS, or the diagnosis, is based on clinical findings and family history. And because EDS has a dominant penetrance through families, there is often a history of many members of the family having similar characteristics to the patient. We do not have a genetic stamp yet. We don't have a fingerprint, but in some areas we have partial prints, and hopefully soon we will have full prints. Also, a supplementary workup is done, especially in patients who have suspicion of vascular type. We look at echocardiograms, we analyze MRIs of the chest or abdomen to look for aneurysms. If aneurysms are present, they're very serious aneurysms. They're not aneurysms such as we encounter in atherosclerosis or aging, abdominal aneurysms of an elderly patient that grows gradually and slowly over time. Once an aneurysm develops in a patient with EDS, it should be addressed as a medical emergency because it's due to necrosis of the media of the blood vessel, and just a red signal that it is an enlarging vessel means that it's like a hand grenade that could go off at any moment, so it needs to be repaired. Now, like EDS, Chiari 1 malformation is also a work in progress. It's undergoing a redefinition continuously. And some of you who go back with me to the time before this paper came out can remember, and some of you can probably still testify to the fact that there are physicians, radiologists, who still make the diagnosis of Chiari based on one sole criterion, tonsillar herniation. And there will be debate among them as to whether 3 millimeters or 5 millimeters is a diagnosis of Chiari. This simple criterion has been used since MRI came along to show these malformations, and it has lingered in the perceptions of physicians. We now know that Chiari malformation is far more than tonsillar herniation. It represents a continuum of osseous disturbances of the paraxial mesoderm. Many different types of osseous abnormalities are seen, and these abnormalities can affect the skull base and the upper cervical spine. They come in great variations, and they convene, in the case of Chiari 1, to result in a dysmorphic, poorly formed, small posterior cranial fossa. That dysmorphism of the skull base results in herniation of the cerebellar tonsils. Not enough space for the tissues that are supposed to be housed within the posterior cranial fossa. With the herniation of the tonsils, there are varying degrees of abnormalities of CSF circulation between the cranial and spinal compartments. And in certain patients, especially young patients, before the central canal of the spinal cord becomes occluded, varying degrees of syringomyelia can occur. So the problem isn't tonsillar herniation. Tonsillar herniation is the result. It is a result of a continuum of mesodermal disorders, mainly of the osseous system, that produce these secondary effects. And with the help of Dr. Marcy Spear and with ASAP's help, because ASAP spearheaded the first grant support to look at the pedigrees and the familial aggregation of Chiari 1 and syringomyelia, we now know that it is either a autosomal dominant trait with reduced penetration, which means it doesn't pass on like brown eyes, but it is an autosomal dominant transmission, or it is autosomal recessive, and it may be either or both in some families. Like EDS, Chiari 1 malformation is a comparatively rare disorder. It's given as an incidence of 1 per 5,000 patients, but I dare say that, as many of you have experienced, the misdiagnosis or underdiagnosis of Chiari may make this far more common than is currently appreciated by the Centers for Disease Control and by general physicians. Patients who have lived a lifelong tag of migraine headaches may be patients with Chiari unrecognized. Patients that have been diagnosed with fibromyalgia or chronic fatigue syndrome may very well be patients with Chiari and or syringomyelia. And when we produced our first study population, 59% of the patients before we saw them had been referred to a psychiatrist. So it gives some idea that this number may grow as we expand the familiarity of the condition. This is an example of the small posterior fossa. In the simple form, the back of the skull or supraocciput is small. The front of the skull base, the clivus, is short. The angle of the tentorium has a low insertion, and volumetric measurements show that the posterior cranial fossa is too small. So what does the cerebellum do about that? It tries to move in paths of least resistance. The superior cerebellum extends often up through the tentorial notch a bit, and the tonsils extend through the foramen magnum a bit, and this produces a obstruction to some extent of CSF flow. I call your attention to the odontoid process, which in this patient with a small posterior fossa is perfectly normal. But in our study population, 35 to 40% of patients have a backward-leaning odontoid known as a retroflexed odontoid, which contributes to the reduced space of the opening of the base of the skull, which is impacted by the tonsil, and it's foreshortened by the retroflexed odontoid. About 5% of the study population, the odontoid extends through the base of the skull, right up into the cranial fossa. This is known as basilar invagination. And here you can see this long bone extending right up to the level of the pons. It produces compression of the front of the brainstem. This is a little shadow of the basilar artery, which is compressed against the medulla, and this produces a neurovascular compression on top of the compression induced by tonsillar herniation. But that's not all there is to it. We now have done 3D CT scans on most of the patients that come through the Chiari Institute. We have a database of 1,200 3D CT scans. And the number of findings that we encounter are astonishing. About 5% of patients have a disturbance, a bifida, or incomplete formed arch of C1. Almost the same incidence of patients have fusion of C1 to the base of the skull. That's known as assimilation of the atlas. Here's a patient with a head tilt who has a little bifid C1 but has fusion of all the bones of the neck. That's known as Klippel-Feil anomaly. We find a significant number of patients who have varying defects of the base of the skull, known as cranial lacunae. And I won't go into all of them. This just sort of summarizes in one patient. A patient who had a little Chiari here that was missed, the base of the skull is here. You can see a basilar invagination of the odontoid. You can see a Klippel-Feil anomaly of the cervical spine. And yes, you can see a syrinx too. So we were very interested when we encountered this subset of patients with Ehlers-Danlos if we could make some comparisons and try to understand the combination of these disorders better. We have a large ongoing outcome study at the Chiari Institute, which is got more than 1,000 data points. It's designed to acquire Class II evidence. There are 9 categories of prospectively collected data, and we try to put in every variable that we have seen, because unless an outcome study controls the variables, what comes out will have a limited value. But what this database does is permits comparisons between different clinical subsets. And so we tagged the Chiari EDS group into this ongoing outcome study. We also carried out a familial aggregation study, which borrows heavily on the study that we did almost a decade earlier with Marcy Spear. And the most important part of this investigation was the inclusion and addition of our colleagues at NIH, and Dr. McDonnell will be representing that. She really is the spearheader of the group there anyway, and she will be telling you the findings that have come to light. So this was a 3-pronged attack. We were looking at the clinical correlates, we were looking at the family history, and we were looking at the genetics. Now, here's at close of business at the end of June, a period. We started at the Chiari Institute in January 2002, an interval of 42 months. We had registered 1,936 patients with MRI-confirmed Chiari 1 malformation. These are prospective patients. They don't include the patients from the years before. In that group, we found 133 patients who met the Baton score criteria and other clinical criteria for Ehlers-Danlos syndrome. An astonishing 6.8% of our patients with joint hypermobility or other features of EDS. 96 of these patients had not had prior surgery. 37 had been referred because of failed Chiari surgery. And those are the ones I referred to. Those are the ones that turned the light on and illuminated the possibility of some connection. In that group of 133 patients, a little more than half were hypomobile type, like the patient you saw illustrated. 54 had the classical type with problems of wound healing and so forth, arthrochalasia. And although this is not classically included in Ehlers-Danlos syndrome, we encountered 5 patients with Chiari 1 and Marfan syndrome. 5 patients, 3 of them now with confirmed diagnoses, the others going through some final diagnostic steps. Marfan's is the granddaddy of the connective tissue disorders. There are some historians who have imputed that Our great President Lincoln had it, but I don't believe that was the case. But these are patients that tend to be long and asthenic, and they have joint hypermobility, and they have, unfortunately, a high incidence of vascular malformations, including aneurysms of the ascending aorta. Now, our database is biased, and that always has to be taken into account when one talks about prevalence studies. We have a very large base of patients who are referred for management of failed Chiari operations. So since that's where we picked it up, the scale is definitely tilted by this experience. And it was further tilted by the fact that when individuals and doctors found out that we had an interest in EDS, we started getting referrals of patients with EDS and Chiari who did not have previous surgery. And some of those patients actually came up to us from National Institutes of Health as patients from our end came down to them. Now, if we just do a generic statistical analysis of what we're talking about, if you took two disorders in the general population with a predicted incidence of 1 per 5,000, the predicted coincidence of these two conditions in any given patient would be astronomical, be in the 1 per 25 million range. We observed the coincidence in 1 per 15 patients in our database. Given the biases, it might be 1 in 100, but it was nonetheless such a staggering difference that this was noted. So our conclusions are that these findings cannot be explained by chance alone, and with or without the database bias. Now, we look more deeply into clinical distinctions in patients with Chiari and EDS who had not had prior surgery, just to look at what differences might we see in symptoms and radiographic findings in patients that have this additional diagnosis. And we compared the 96 patients with a database of 887 patients, and we found a statistically increased incidence of symptoms including nausea, difficulty swallowing, hoarseness, sleep apnea, palpitations, dysautonomia, POTS syndrome, shortness of breath. These collectively tend to be symptoms of anterior brainstem dysfunction. They had the other symptoms. They had the Valsalva-related headaches and so forth. But this is what we usually see in patients with basilar invagination, retroflexed odontoid, and it is a signal that the anterior portion of the brainstem at the foramen magnum has some abnormality. When we looked at the radiographic findings, we found an increased incidence of pannus formation. I'm going to show you what that is, but it's a thickened capsule around the tip of the odontoid that can compress the front of the brainstem. And then a variety of skull-base abnormalities, which I'll also show you, that we did not see. Occasionally we would see, but did not see with any significant incidence in patients with Chiari 1 alone. And we found a very much increased incidence of problems such as supraventricular tachycardia on EKG, mitral valve prolapse, even tricuspid valve regurgitation, the POTS syndrome. And 24% of the patients had a positive response to cervical traction and axial loading tests. That's when the patient is in the office and you elevate the head on the neck or you press down on the head. The patients that we deem as positive are those that have relief of symptoms, such as these, with cervical extraction and the magnification of those symptoms when the head is pressed down on the neck. When we looked at patients with failed Chiari surgery, we compared our 37 patients with both Chiari and EDS to a larger database of 925 patients. And we found in this group of patients coming in that they had a rich history of poor wound healing, history of CSF leak from their posterior fossa decompression, but from other spinal operations, even from lumbar punctures done in the past, and a higher incidence of infections, primarily secondary to CSF leak. Now, these patients tended to present predominantly, the reason they would come in, the problem that was the result of caused them to be seen, were predominantly anterior brainstem symptoms, the ones I mentioned, nausea, hoarseness, difficulty swallowing, and so on. In these patients, we found an increased incidence of pseudomeningocele formation at CSF collection outside the dura, beneath the skin. We found that the incidence of cerebellar ptosis, or the entire cerebellum coming down after decompressions, was increased, and we found an increased incidence of craniocervical instability. Almost 70% of these patients had a positive response to cervical extraction, better, or axial loading, worse, on clinical examination. This is a 3D CT of a patient with Ehlers-Danlos Syndrome, and it has some interesting features. This patient, like many of them, have a short mandible. You can tell that by the presence of an overbite here. It also accounts for the fact that postoperatively our patients often have increased difficulty for a week or so after surgery with swallowing. They have a normal-sized tongue in a small oral cavity. This is not a good example, but it happened to be in a patient that had other things. This is Ehlers syndrome with a styloid process, which is usually a little bone that begins and ends about here, can extend down like the teeth on a saber-toothed tiger. And this is called Ehlers syndrome. This patient, if you look at the face, there's a mild degree of hypoplasia. There is a mid-face hypoplasia here. Many of these patients with EDS and Chiari have sinus, a long history of sinus disturbances. There's also the flat supraocciput, so you can see the head looks like it's sort of compressed. So we have some interesting findings. These are findings that would not be picked up by a radiologist nor ourselves if we hadn't been alerted to it. There's a high incidence of temporal mandibular joint problems in these patients, and here we see an example of that where the temporal mandibular joint is really impacted. There is no joint space here. So this patient brings together a lot of very subtle osseous disturbances in a patient who has Chiari, but also has a connective tissue abnormality as well. This is pannus deformity. Here's a tip of the odontoid, which is a fairly normal straight odontoid, but you can see a big black shadow here, and that's represented by a thickened capsule. This is the base of the skull here, and you can appreciate there's a tonsil here. There's really an obliteration of the CSF spaces, which are shown white here at the tip of the tonsil and behind the tonsil. But there's also a compression, a basilar impression of the CSF spaces in front. So this patient, who would probably be called a Chiari patient by a radiologist, although you never know, has, in addition, compression from in front and compression from in back. And the anterior compression accounts in this patient for the high incidence of problems such as dysphagia, sleep apnea, and so on. And this is what we typically see in patients referred for operation with pseudomeningocele formation. Here's a cerebellum that's sort of dropping down almost like a lead weight, doesn't have its normal architecture. There's a big fluid collection behind here. This is a pseudomeningocele. The pseudomeningocele is tracking into the cervical spine. Just a word on what this craniocervical instability is all about. We believe it's due to hypomobility of the craniocervical junction, where the head joins the neck. This usually cannot be demonstrated radiographically, but the micro movement at the joint over time produces thickening of the capsule around the odontoid and leads to the pannus formation. So the basic cause of craniocervical instability in patients with the EDS component is this hypermobility of the cervical medullary junction, the micro movement of the odontoid, the formation of a pannus, and this may all be radiographically negative. So how do we suspect this diagnosis? Well, now we're alerted when a patient comes in with EDS to look for these things, but distinctive symptoms of anterior brainstem dysfunction, if these are predominant in a patient with Chiari, it's suspicious. It should be investigated further. The presence of a pannus formation, and this can happen in patients with Chiari and no EDS, but it's another red flag of possible diagnosis. And then if the patient is strongly positive to cervical extraction, axial loading test, that is another diagnostic point of interest. The definitive diagnosis as to whether patients have craniocervical instability that is not provable by radiographic studies, is we admit patients for 24 to 48 hours of invasive cervical traction. That means we put tongs on, we suspend them to a pulley, we add weights. If the patient clears their symptoms, and I mean clears them, not just I feel a little better, but by lifting the head off the neck, they say, Dr. Milhorat, I feel like $1 million. Their symptoms are all gone. And if we take the weights off and their symptoms become exaggerated again, over a period of 24 to 48 hours at different weights, we can establish, in my opinion, definitively that we have functional cranial settling as a diagnosis. Now, some of these patients came to surgery. I'm going to go through this rather quickly because I'm looking forward to hear what Dr. McDonnell has to say. Our indications for surgical treatment are known and they've been published. If there's clinical progression, neurological deterioration, syrinx propagation, those are obvious. The vast majority of patients are those who have intractable or disabling symptoms, and we set a rather rigid cutoff at 70 Karnofsky score. They have to be below 70. 70 is when a patient starts to be unable to perform normal activity, and the disease limits their ability to do active work. Above 70, 80, and 90, these are nuisance complaints, and there may be a time when the diagnostic and surgical indications will go higher up the list, but right now we've done below 70 as our cutoff point. Now, the operative treatment in these patients with both Chiari-1 and EDS, with a follow-up of just a little more than a year, so I add that as a cautionary note. Of 96 patients with no prior surgery, 41 were surgical candidates. The mean Karnofsky score in this group was 67. Most of the patients got either a posterior fossa decompression or a combined posterior fossa decompression with a craniocervical fusion and extraction. I emphasize in extraction. This isn't just fusing the patients. They have to be extracted and then fused in that position. And of the 36 patients we did, 4 of them developed instability and had to be fused. So in this group of just 41 patients, 9 patients have had craniocervical fusions and extraction. It's about 1/4 of the patients, or 25%. In patients, they also had some other operations that went along in some cases. In patients with the failed Chiari surgery and EDS, all 37 came to surgery. The mean Karnofsky score was lower here, it was 59. The patients 14 of the patients had just simple revisions of pseudomeningocele or enlarging or shrinking tonsils or something of that order. But 16 patients, the primary operation that they got, the only operation that they got was a craniocervical fusion and extraction. These are the outcomes, and it's a brief follow-up. 41 patients, 37 patients. We had our share of wound healing problems. We had our share of superficial wound infections. One was a methicillin-resistant staph. Mercifully, we've had no deep wound infections. We've had 2 instrument failures as we converted from a Cervifix to a Danik system, which I hope takes care of that. We've had no CSF leaks, and we've had no pseudomeningoceles. These patients with EDS and Chiari have really been helped. The mean improvement in Karnofsky score has been a +25, and they're functioning around 90, which means they have some symptoms as a group. And the patients with failed Chiari surgery, even a greater increase, and they're restored to a pretty good clinical condition. The problem is, this is a very short database, and I don't want to be held to any of these results as being what they will be as time goes on. Now, the young woman that you saw doing the demonstrations is an interesting young woman. She is an EMS technician from South Carolina, and she had had a very well and competent posterior fossa decompression in 2002, after which she was basically disabled and unable to work. And this demonstration that she did was done 3 weeks after she had had a craniocervical fusion, which she is concealing here, I think, fairly nicely. But she has been restored to almost normalcy and is able to do things she hasn't done in years. So I think this functional cranial settling is a big deal. And now that we've seen it, I hope other people will look for it. And there'll be many implications, I think, in the management of patients with Chiari, which I will sum up in just a minute. One final thing, the results of the familial aggregation study that was carried out, it's too busy, there are too many points here to discuss. It's simple enough to say, and sufficient to say, that Chiari and EDS shows up 2 or more affected members in a large number of families, multiple members here. If you add those that have both conditions and Chiari only confirmed, EDS only confirmed, we're talking about more than 50% of the patients have a familial history of this condition. And we're still working on those where we suspect the diagnosis, but family members haven't had MRIs or Baton scores done. But we're looking at huge numbers of patients. 90% of the families have either multiple members that are confirmed or suspected. So this doesn't prove anything, but it's just another evidence that something is going on. In order to find out what's going on, we've turned to molecular biology and genetics, and I'd like Dr. McDonnell to take the next part of the presentation.
We've been very fortunate to be working with the Chiari Institute on the patients with Ehlers-Danlos syndrome and related connective tissue disorders. We're located at the National Institute on Aging in Baltimore. We are a branch of the National Institutes of Health, and we are actually the laboratory of genetics. We have a protocol where we enroll patients with diagnosis of Ehlers-Danlos syndrome, Marfan syndrome, Stickler syndrome, and other closely related disorders that involve, that fall under hereditary disorders of connective tissue. The way we became alerted of the connection between Ehlers-Danlos syndrome and the Chiari-1 malformation was through several patients who came with a diagnosis of Ehlers-Danlos syndrome and who had already had surgery for Chiari-1 malformation. We had 2 patients like that, and we started thinking that some of the symptoms that go with Ehlers-Danlos syndrome, and especially the autonomic dysfunction syndromes, could be due to Chiari-1 malformation in these patients. On the basis of these, the symptoms and the presentation, we have referred a number of patients to the Chiari Institute for evaluation, and we have had some results. But I will go into that in a minute. I do want to review the classification of Ehlers-Danlos syndrome and explain the molecular mechanisms that lead to it as far as we understand them, and I'm hoping that that would give you some insight as to the connection between Ehlers-Danlos syndrome and the Chiari-1 malformation. The classical form of Ehlers-Danlos syndrome, now classified as classical, previously as types 1 and 3, are manifested by the joint hypermobility, the skin being elastic, as well as abnormal scar formation and the presence of easy bruising in the history. Dominantly inherited, about 50% of patients with classical form of EDS have mutations in collagen 5. Almost on a continuum, I'll have to say, is the hypermobility type of Ehlers-Danlos. The majority of the genetic basis for hypermobile form is unknown, although TNAS and X has been recently implicated and may account for a significant percentage, maybe as much as 10% or more of hypermobile type. But once again, the genetic defect has not been clearly described for the hypermobile form. The characteristic of hypermobile form is the presence of dislocations. Typically, these patients do not have the same amount of skin involvement as the classical form of Ehlers-Danlos. Typically, they do not form scars that are unusual. However, especially in a younger patient, it can be difficult to determine if there are skin findings or not, because the young skin is typically more elastic or stretchy. And the patients may not have had an opportunity to develop scars. They might not have had surgeries or injuries that may lead to scars. So there have been many instances where I have seen a teenager who does not have any scars, and I would think that they have the hypermobile form of EDS based on the clinical exam, until I see their parent, a mother or a father, who is just as hypermobile but has atrophic scars because that person has had the opportunity to develop those scars. So the distinction between hypermobile and classical can be difficult. The vascular form of EDS is the diagnosis I do not like to make because it is actually associated with a reduced life expectancy. The classical and hypermobile forms of EDS can have significant morbidity associated with them, but do not necessarily lead to a reduced lifespan. The vascular form of EDS, the life expectancy is about 50 years old due to the presence of aneurysms as well as the risk for bowel and uterine rupture during young adulthood and sometimes even during teenage years. So it is a grave diagnosis to make, and when we do make it, we like to have a confirmation with molecular testing through protein analysis as well as hopefully identification of a mutation with the collagen 3 abnormality. The subsequent forms of EDS are the rarer forms, the kyphoscoliosis, arteriochalasia, and dermatosparaxis. These are, make a very small percentage, more than 90% probably actually of EDS falls under classical and hypermobile and vascular. And of those, the vascular is the rarest. Hypermobile form tends to be the one that is most often missed by the primary care physician or in terms of referral. One other thing I would like to add here is that for the hypermobile form of EDS, there is often a pain syndrome that is associated with it that is disproportionate to the findings on the joint exam. This pain syndrome is for real, and often patients have associated autonomic dysfunction as well. We do not yet know that all of this autonomic dysfunction we are seeing in EDS may be related to Chiari and related disorders. There is reason to think that it may actually be an intrinsic part of Ehlers-Danlos syndrome, but the work on this is ongoing. So this next slide actually outlines the molecular complexity of collagens and extracellular matrix elements that might be implicated, are implicated, and some of it may be implicated in the hereditary disorders of connective tissue. So this is occurring. These are the collagen molecules. There are different forms of it. There are actually at least 20 collagens known, but they make up different trimers that are actually secreted into the extracellular matrix and make the glue of the body, the part that holds the body together. So in the classical form of EDS, there can be what we call haploinsufficiency, or insufficient quantity of collagen 5. This is because one copy in the body has a mutation, and actually the transcript is degraded, and sufficient amounts are not transcribed, and there is a decrease in the amount of collagen 5 synthesized. So that explains part of the classical form of EDS. Some of the other parts of the classical form of EDS are actually related to the fibril formation in the extracellular matrix. The collagens ultimately make these fibrils that lay down the extracellular matrix. So there are other associated disorders such as osteogenesis imperfecta that result from collagen 1 deficiency. This is also known as the brittle bone disease, where, and there are different forms of it. but the patients have an increased risk of fractures, and this could be even infants who were suspected of child abuse and so forth, and what they have is a deficiency of collagen 1 that leads to brittle bones. The collagen 1, in addition to being involved in osteogenesis imperfecta, is also implicated in the dermatosparaxis and the arthrochalasia forms of Ehlers-Danlos. These are actually recessively inherited because they are related to the processing enzymes that put together lead to the final form of the collagen. In the vascular form of EDS, collagen 3 is implicated, and this collagen 3 is found in predominantly in blood vessels, and that's why we do see the increased incidence of aneurysms in this population. The extracellular matrix of it as part of this is what I would like to emphasize. So there is a lot to be found out yet as to how the collagen gets organized in the extracellular matrix. The deficiency may not be in the collagen gene itself, but may be involved in one of the protein products or genes that transcribe for these, that code for these protein products that help organize and lay down the collagen in the extracellular matrix and how the collagen interacts with the cell. And this is the area that is of the greatest interest to us because I think this is where the money is going to be in terms of hypermobile form of Ehlers-Danlos. And we're always looking for new genes that may be implicated and that would eventually explain the genetic basis of the hypermobile form of EDS and 50% of classical EDS for which the genetic defect is not yet described. In terms of the connection with the Chiari-1, to date, we have referred about 20 patients to the Chiari Institute on the basis of symptoms that were suggestive of a Chiari-1 malformation out of about 70 patients with a diagnosis of hypermobile or classical forms of EDS. And not all of them went for the evaluation as of yet. But of the 8 that did go, all of the patients who were referred either had the Chiari-1 malformation or a related disorder without the full malformation, which would be the retroflexed odontoid or other abnormalities of the odontoid that were causing the autonomic dysfunction type symptoms or the anterior brainstem type symptoms. So a summary of the chronic, the symptoms in this group of patients included chronic severe headaches, migraines, neck and shoulder pain, autonomic dysfunction, meaning instability of the heart rate, hot and cold sensation, dizziness, postural orthostatic tachycardia, syncopal episodes, sleep disturbances of various sorts, could be sleep apnea or poor sleep architecture. They often do also have photophobia. In terms of their physical exam, abnormal palate and pharynx is actually fairly common in Ehlers-Danlos, but every single patient who was referred and was found to have the Chiari malformation did have an abnormal palate and pharynx, meaning usually a very high and narrow palate and a wide posterior pharynx. They also had a displaced or absent gag reflex, blepharoclonus, which is a beating of the eyelids when the eyes are closed, a rhythmic beating of the eyelids. They often had generalized hyperreflexia. Some of them actually had asymmetric lateralizing neurologic exams. On their craniofacial characteristics, they also had often a flattened occiput. Cervical kyphosis or flattening was also common. Another feature of these patients was the endocrine abnormalities. A number of them had premature ovarian failure, meaning early menopause, often in their 30s. The males who were referred had low testosterone, and many of the patients had hypothyroid.